Good afternoon and welcome to the inaugural symposia organized by the Pacific Group. I'm Dr. Bhaskar Bhattacharya and I'm representing the Pacific Group. Pacific is a pan-Asian organization headquartered in Singapore with operations in the Philippines and in India. In India, we're located in Salt Lake, Kolkata, and are known as Pacific Oncology Multispecialty Polyclinic, or POMP. So POMP, or Pacific Oncology, is a one-stop shop providing expert consultations by renowned specialists in Eastern India and indeed in the whole of the country. More details can be obtained by visiting our website at www.pacific.in or from our Facebook and Instagram pages. As we all know, the second wave of COVID-19 has ravaged the world and India has taken an exceptionally bad hit. Many of us, including myself, have tested positive and have witnessed the devastation around. But a lot of us who are recovering are facing numerous health issues and have unanswered questions such as what to expect on the road to recovery. As a part of our awareness program, we aim to spread information, especially on what to expect post-COVID-19 infection. The first part in the series will be dealing with COVID-19 and diabetes, an alarming trend which has been observed but not yet fully addressed. The session will be moderated by me and Dr. Shumanta Dotto. And on our expert panel, we have Dr. Gaurav Bhaduri, who's a practicing endocrinologist with special interest in diabetes, and Lieutenant Colonel Dr. Shomnath Kundu. We are very thankful to our panelists for giving us the valuable time for this very special webinar. So without further ado, we will start with Dr. Bhaduri. Everyone, welcome to this webinar. So Dr. Bhaduri, my first question to you is that as an endocrinologist with a special interest in diabetes, like you've been seeing several diabetes patients throughout your career. So what are some of the major differences or striking differences you have noticed between the first wave in 2020 and the second wave in 2021?
The astronomical figures that has happened in the second wave has actually unmasked a lot of things that we didn't get in the first wave. It's a direct function of numbers, because the more number of cases you get, you tend to get a variety of them. So what has happened in the second wave is we have come across not only affecting COVID, affecting the metabolic part from the diabetes point of view, but also in terms of thyroid, we have seen a lot of thyroiditis also happening. And we also have seen that, because of the high degree of inflammation, there is sometimes even affecting the gonadal systems also. So we have started seeing cases of orchitis also. And there may be some reported cases, though I personally haven't seen them, but I have seen it in the papers being reported regarding functional hypopituitarism also, and plus minus there is some adrenal insufficiency, which might not be to a very great degree, but it is more like the related with the critical illness related adrenal deficiency. So these cases have started to come up in the second wave, which we were not getting that much in the first wave. The first wave had only cases where we saw different types of fluctuations in blood sugar levels due to the effect of COVID-19 that has on the metabolic parameters. So this is one thing I like to highlight, that not only diabetes, but other systems of the endocrine systems are also getting affected. And a proper eye on all the systems of the endocrine system should be kept in mind. Obviously, the numbers, if you talk about 90%, 95%, is obviously the main concerning thing is related to hyperglycaemia, which might be temporary, which might be because of the steroids that are being used to treat patients of COVID-19. And in cases of known patients of diabetes, this can also be, the highs can continue for a significant duration of time.
Right. So according to you, it's the just the sheer number of cases which we're observing right now.
Yes.
And obviously, the practice of steroids that started recently, after the Solidarity trial, where it was mentioned that, corticosteroids are useful. So in the first wave, not a lot of people were treated with the steroids. So it could be a part of the therapeutic regime which has been adopted, or, it's just for the sheer number of patients we are observing these trends.
No, for diabetes, I think the trend was also there in the last COVID wave, which we encountered, and we saw patients who had either a pre-diabetes their diabetes being unmasked, the insulin resistance they already had. Actually, see, the problem with diabetes is that when you make a biochemical diagnosis of diabetes, that is, your fasting goes beyond 126, your oral glucose tolerance goes beyond 200, and or your HbA1c goes beyond 6.5 or touches 6.5 and beyond. So this biochemical diagnosis of diabetes is something which we rely on to make a diagnosis of diabetes. But the process of diabetes starts even much earlier, maybe 5 to 7 years earlier. So even if you are in the normal glycemic range, or your sugars are absolutely in the normal fasting PP as well as your HbA1c, you still may be having an internal resistance within you, which might be unmasked later on as the natural course of diabetes progresses. So sometimes it's very difficult to pick these cases up. You may have a little bit of suspicion in those patients who have multiple family members with diabetes, but sometimes even without those history, some of the patients are at higher risk. So what COVID-19 has done is COVID-19 has elevated the blood sugars in them who are already having diabetes. That is one part. Many patients, without even being steroids being used, we are seeing a spike in the blood sugar levels. There are different hypotheses for it. I will tell that later. But this is what we are seeing. Second is the category where the patients are pre-diabetes, and then their blood sugars have gone beyond the diabetic range. Okay, so these patients have become diabetic after being infected with COVID. I am not talking even about the use of steroids in these patients. And even I have seen some documented patients with family history of diabetes, already tested, HbA1c absolutely normal. So those patients have also gone on to become in the diabetic range after the infection with COVID, though the numbers are less comparatively, but yes, this is also happening. So that is we are calling as acute new onset diabetes. Okay, so some of my patients require the treatment for some duration of time, and now I have stopped all medications. I have been able to stop medications. So we are actually learning about this, that how permanent the issue is, or whether there is an underlying insulin resistance which might put the patient always at a risk for further progression into diabetes. Now, when we use steroid, obviously you expect a rise in blood sugars, and during the period of COVID, always this has to be managed by use of insulin, and this use of insulin should be adopted properly to control the blood sugars when there is a spike, uh, when the patient is already diagnosed with COVID-19, and especially when steroids are being used.
Right. In the case of insulin resistance, I mean, it's going to be a different story then. So, but we don't know, because the follow-up needs. Okay, so hinting to your hypothesis, I think I'll pass on to Dr. Shamanta Datto to come up with his next question for you.
Thank you, Dr. Vadari, for explaining a little bit detail in that. So yes, it is important to emphasize firstly on diabetic changes because it is now kind of having a major effect following COVID or during COVID infection. So what do you think how the virus has got a role to do with this hyperglycemia? Is there any prevalent hypothesis at this point?
Yeah. So it is being believed that the ACE2 receptors is there in the pancreas. So this is there in both exocrine as well as the endocrine pancreas. So what is happening is that the virus might directly go and bind, and may, the insulin generating cells are the beta cells of the pancreas. So the virus can go directly and bind to them and cause apoptosis of those cells, which are responsible for production of insulin. This is one mechanism. Another is that we all have understood by this time that there is a very high degree of inflammatory cascade that goes on once the virus is replicating inside, and this leads to a cytokine storm later on. So because of the inflammatory cytokines present in the body, so that is also an inhibitory factor for the pancreas to keep on generating insulin and sensing the high blood sugars and generating the adequate amount of insulin. So these are the two main pathophysiologies that has been advocated. And another one is that we know the adipose tissue release something called as phyutin A. So this molecule also has a role in the inflammatory process, and this virus is actually stimulating the adipose cells to produce this more, so creating more of insulin resistance. So one side there is a defect in the insulin production by either direct apoptosis or killing of the pancreatic beta cell by the virus, or due to the very high inflammation, the pancreas is not able to generate enough insulin and also causing insulin resistance. And also through the action on the adipocytes, there might be also release of certain chemicals which can lead to a insulin resistant state. That is why we have seen that those patients who are obese and have a higher risk of getting severe COVID and high mortality. So this is probably being related together.
In between, before we move on, so we have a question from someone who's attending this. I mean, you've been saying that, is there any role of cytokine storm in hyperglycemia? So I think you did explain that like there's various cytokines which are released, and they can have an effect in hyperglycemia and other.
Definitely an effect.
Yeah, okay. And there is another question.
And I will tell you, the problem is that we use a corticosteroid to get, this cytokine storm to, inhibit the cytokine storm. And that also leads to an increase in blood sugars. So whether it is the cause or whether it is the prevention, both might lead to an increase in the blood sugar level. So that is where the challenge is.
Right. Right. And there is another question, which it appears that it's coming from someone who's suffering from COVID. And today is their 27 days, post COVID-19 exposure. They are recovering, but they have one problem: they have little cough with mucosal discharge from chest and the pharynx. And this person was a diabetic hypertensive, but after COVID-19, they are observing that there is a drop in the blood pressure, hypertension. So I think this is a question for Dr. Kundu, although we are just going out of the trend over here, but this is a question which has come up. So Dr. Kundu, can you please help answer this question?
The patient happens to be a diabetic and a hypertensive on medication, so far as I come to understand. He is on his 27th day of recovery. So his question is primarily after COVID, his blood pressure is ranging from 110 to 70 to 100/64. So he has stopped hypertensives for medicine. My answer would be, for the time being, he should stop his antihypertensives and be kept on regular daily monitoring. He should buy one digital blood pressure instrument and keep it at home, keep on monitoring regularly. Like two or three patients right now I have like this, identical patients. So I have advised them to keep on monitoring daily, and I keep a tab on the blood pressure. So if it begins to shoot up, then I will reintroduce them. So that's my advice.
Dr. Bhaskar, I would say that these patients, if they have suddenly stopped the requirement of antihypertensive, this is happening. Okay, with my patients also, this is happening. Most of them would need antihypertensives later, maybe 2 to 3 months later. We are restarting the therapy, maybe much graded. We're starting with very slow dose medication and then gradually up titrating as per the need of the patient. But one very important thing is to check the sodium and the potassium. So because I told you that some of the patients might be having a subclinical adrenal insufficiency also. So if it is happening, then we might pick it up. So this is, though it is rare, but especially if the potassium is on the lower side and we are using something like a diuretic in the hypertensive medication, so that needs to be curtailed later on while adjusting the medication when the patient again requires it. So this is a subtle thing that I think should be kept in mind.
Right. And we were going to come to this question, but Dr. Ranit Bagh raises this question of importance of post-COVID monitoring for new cases of any, effect on the endocrine system.
Yes, very, very important. Okay, especially on the diabetes point of view, we must be monitoring the, self-monitoring of blood glucose. So you can easily do that at home with a glucometer. So you should be checking at least your fasting blood glucose levels. If you didn't have any diabetes before, so at least the fasting and maybe the any major meal what you take. If your breakfast is your major meal, then you can check your blood sugars 2 hours from the start of your major meal of the day. So at least these two readings should be taken in a maybe if the patient is non-diabetic and the readings are coming okay. So at least maybe once or twice in a week, the patient should be checking this. And if the patient is a known diabetic, and then the intensity of checking should obviously increase. and we decide that based on what the patient requires currently, whether the patient will be requiring oral therapy. We can go, because during the period of COVID, it is very if it is in the very mild side, it's okay to still continue with some of the oral medicine, not all. But if it is in the moderate to severe range, it must be insulin and insulin only during the period of management. Post recovery, depending upon the status of the patient, we can take a call whether to keep the insulin on for a little bit of more duration, or we can come back to the original oral prescriptions the patient was taking. And depending on that, the intensity of the sugar monitoring is also very important. So I believe that because the numbers are growing every day, so it is better for even those patients who have never been diagnosed as a diabetic or maybe even pre-diabetic. So those patients should check their blood sugar levels for a decent amount of time, maybe 2 to 3 months at least post-COVID, and then take a call based on what their doctor tells them to do.
Okay, and we have another question, which is quite interesting. So this is from, obviously, like I understand, someone who's not a clinician or a scientist. So this individual wants to find out that how COVID-19 and steroids actually increase the risk of diabetes, and in simple terms, if possible.
Okay. So COVID-19, I explained to you that the virus can attach itself by the ACE2 inhibitors in the pancreas directly, and can cause the death of those cells from where the insulin is being generated. This is one possibility. Another is because of the cytokine and the inflammatory storm that goes inside your body. So that might also be a barrier to insulin generation as well as insulin action. Okay, that we call as insulin resistance. Some of the chemicals that are being released does not allow the insulin to work properly. So this is a method by which this happens. With steroids, it is more on the side of insulin resistance. So both of them can together lead to a very high spike of blood sugars during the administration of steroid in a COVID-19 patient. So it is very important to select the right kind of patient in whom the steroid should be initiated and at what dose and how to taper it. So it is very important. So if there is an indiscriminate use, because in India, we know that steroids are available as an over-the-counter medication. Unfortunately, this is happening. So anybody can go and, some of my patients are telling me, I'm yet not having any COVID, but can you prescribe me some, steroids so that I keep it at home? And if I becomes positive, then I will take it. So this is very, very dangerous. So COVID, diabetes and steroids, they have got a very, very close relationship. And steroids can be a life-saving medication if used properly in the right patient, but it can have a devastating effect and catastrophic effect if it is used inappropriately.
Right.
Okay, thank you, Dr. Bhadri. So it was a very scary situation, particularly knowing the fact that in India, we have got a massive number of diabetic patients. It is endemic in our country, isn't it? Because we are genetically prone to have diabetes, mostly type 2 diabetes, isn't it? So the modus operandi of COVID and the COVID treatment can act in both ways, like how we do in insulin deficiency in type 1, or maybe increasing the insulin resistance in the periphery, like in type 2. So is there any difference between these two types of diabetes during the COVID or post-COVID period, how you manage?
Yeah, so if a patient is already known type 1 diabetic, then with these patients, COVID-19 infection can precipitate something what we call as ketosis or diabetic ketoacidosis or ketosis. So this is something as really worrisome. So any patient who is a known diabetic type 1 patient, if the patient starts having fever, so they are already instructed by the doctors to follow something which we call as sick day rules. So they should be following that. They should be checking their blood sugars more intensively. And if they have a diagnosis of COVID-19, then there will be a lot amount of glycemic variability is increasing that we are seeing. And it is more in the type 1 patient than in the type 2 patient. So a more intensive monitoring and adjustment of the insulin dose, because we know in type 1 diabetes, insulin is the only mode of therapy that is available. So with type 1 diabetes, insulin adjustment and taking care of more intensive glucose monitoring is something which is very, very important to avoid the situation of ketosis. In type 2 diabetic patients who are well controlled on oral medications or even with insulin, after the effect of COVID-19 and with the use of steroids, their sugars might just spike up. Even if they were very, very well controlled, their HbA1c was less than 7, their fasting was in around 100 to 130, PP was in between 140 to 180. So even these patients are also showing a very high spike of glucose. And some of the patients, I will tell you what is happening is that because of testing, they are getting to know that they have diabetes. So they are getting to know they are having diabetes for the first time when they're affected with COVID, and they are also required steroid at the same time. I just saw a few days a lady in around 55 years of age coming to know about that she has diabetes for the first time when her doctor has prescribed a steroid, and before prescribing steroid, he has asked to go for a fasting and HbA1c, and the HbA1c came 9. So this kind of situations are really scary both for the doctor and the patient, because once the steroid will be put on, the sugars will spike even in a patient who is well controlled. And you can imagine what will happen in a patient who is already so uncontrolled diabetic, and that feature was not known previously. So yes, we manage the patient. The patient is currently doing well, but there has to be intensive monitoring from the doctor's side also in this kind of cases, because you will need to adjust the insulin doses according to the response. You can start off with some around at least 0.4 units per kg, but then you have to adjust the insulin doses very, very carefully and titrate accordingly. So these are the kind of challenges we are facing with type 2 diabetes. But type 1, yes, it's very, very important that they can land up into ketosis.
Good.
Right.
Thank you. Thank you.
Thank you, Dr. Bhaduri. Another question is that I'm assuming, this is Dr. Ranit Bagh. He asks, can we prescribe low-dose steroid in OPD-based management in a diabetic patient with COVID-19?
Yes. So first of all, you will need to justify your use of steroid. It should not be very indiscriminate use of steroids in any COVID-19 patients. So if you really think that this patient there is a very good, the benefit is far outweighs the risk, then you can prescribe it, but you must ask the patient to consult with their diabetologist and endocrinologist to get the sugars in control, because very high blood sugars with that will spike. Along with it can lead the patient to go into more of immune suppression. So that can be a counter, productive for the patient.
Right. So I think there's another question is, what's the role of the renin-angiotensin system and COVID-19 infection? Is there a connection?
Yes. The adrenal glands are actually also having ACE2 receptors, and if you look at the surface area to ACE receptor density, it is one of the highest in the adrenal glands. So I told you that there is always a risk of having a little bit of adrenal insufficiency. Sometimes it might be a little bit subclinical and temporary, but especially in those patients who are admitted and having severe COVID. So it is more like the critical illness related adrenal insufficiency kind of stuff. But yes, that attention must be given, as I told you also, to monitor for potassium, at least sodium potassium, at least potassium monitoring must be taken up in those patients where you are suspecting that.
Right.
Good.
Okay.
Next question to Dr. Bhaduri. So do you think this changes in insulin resistance is reversible or it is permanent? What do you think? What is your guess? It may not be proven yet, but what do you think?
No, the thing is that the insulin resistance, will be, if you're using steroids, the insulin resistance will increase for a certain duration of time. If there is some amount of weight gain, if you can get back on the weight when the steroids are put off, then you can reduce your insulin resistance to your baseline level. With COVID-19 also, most of my patients have come back to their original prescription within as early as 2 weeks to as late as 3 months. But usually they are coming back. Another thing what we have seen is a new onset diabetes. So new onset diabetes, what we have seen is in those patients, some of my patients have come off all medications by now within 6 months period. So some patient might have come off medication by 2 to 3 months. Some have come up at 6 months. Some of my patients are still on medication. So that is from the first wave. So I need to see and follow up with patients and see what is the outcome in the coming days. So till now, I would say more on the side of temporary, lesser on the side of maybe permanent. Most of my patients have recovered by now.
Do you think those people who had their beta cell destroyed, they may be permanent compared to those who develop resistance? Because the mechanism is kind of combination of both. So if you
Yes.
develop insulin resistance, that may be recoverable. Maybe that is
Yes.
temporary. But whereas your insulin production is diminishes because of inflammatory changes, that may have some long-term issues, isn't it?
Yes, actually, see, what is happening is that I would say that we are getting a lot of unmasking of diabetes. Okay, so there was some element of insulin resistance beforehand, and then it is getting unmasked because of either COVID or COVID plus steroid. So that aspect needs to be taken care of separately. In a patient who you assume is having no such parameters, body weight is okay, no family history, fasting PP, HbA1c documented previously having an absolutely normal range. So in this group of patients, if you are saying it, see what happens is that beta cell death also happens in type 2 diabetes also, not only in type 1. Type 1, the damage is extensive, okay, and it starts at a very young age. So by the time the patient reaches a certain age, almost all the cells are gone. So there you see a permanent insulin dependence. In type 2 diabetes, the death of the beta cell or the beta cell mass and the function is a proportion of time. So with time, it reduces. So also we see a lot of beta cell death and loss of function in type 2 diabetes also, where there is also insulin resistance. But that doesn't always mean that the patient will be requiring insulin or any medication, because if the damage is very small, then and along with the initial insulin resistance also, the sugars might go up. But once the insulin resistance come down and there may be a few beta cell death, and if the patient is young, we can see a complete reversal by a few months.
The another question I've got in mind is that this adrenaline insufficiency, do you think it is steroid related or completely just
No, completely
COVID-19?
related. I did not pick up with the use of steroid and then sudden withdrawal of steroid. That is why I told you steroid should be initiated. If it is a very, very short term, then there is no need to taper. But if it is for a little bit longer duration, there is a very much need to reduce and taper the steroid medication so that the patient does not go into that adrenal crisis. But apart from the steroid, I'm saying that for severe COVID infections in the hospitals, especially those patients who are on some kind of invasive respiratory support, those category of patients might also be having some degree of critical illness related adrenal insufficiency. So that is a possibility there. But in our routine practice, in our day-to-day practice, what in OPDs, the cases we encounter is usually the mild to maximum moderate. Okay, so in those patients, adrenal insufficiency is a plus minus area, might be having some subclinical cases. So and it is obviously reversible. So we are seeing the reversal happening within a period of few months.
True.
And the crisis is obviously not that that dangerous, like a very sharp fall. And if you don't manage it with hydrocortisone, the patient is not going to survive. Not that category we are seeing in the OPD patients, but in the really sick patients, it is something which must be looked into by internists who are dealing with these patients in the ICU.
Right. I think one more thing which I have, and this is not entirely out of context, is that, like post-COVID, a lot of people are going on different dietary supplements, like to, either to, like gain weight or, sort of get back, the usual strength. So a lot of these dietary supplements, they have branched-chain amino acids. Now, do you think that could be detrimental when we talk of branched-chain amino acids and insulin resistance?
Yeah, so what I actually don't believe in much of nutritional supplements. Okay, so I believe that if you are planning your diet properly, so you can get almost all the nutrition from your diet itself. Yes, for those patients who are hospitalized and cannot take an normal food intake, they cannot have it. You have to give it through the Ryle's tube, or you have to feed them through other mechanisms. So then that issue is separate. I'm not talking about those issues. Okay, so there the nutrition is a completely separate entity and a separate job. So there you can give all the nutritional supplements, obviously in the ratio where it is warranted. Okay, so but in normal patients, I would tell them that you get back to a healthy diet. Okay, so if you don't understand what is your requirement, consult a registered dietitian. They will plan it for you because it's a lengthy job. Okay, so we doctors, many of my patients says, doctor, you prescribe me. So I said that if I prescribe you, I will hand over to you a fixed format. Okay, that is printed, and that is not customized for you, because I don't have a time of 45 minutes or 50 minutes to deduce the calorie requirement and calculate everything for you and make it and give it to you. So there is a time constraint. So what happens is that my dietitians or the registered dietitian, any registered dietitian, who can give it to you. They have to work very hard for it. So you take that consultation, get your diet in order, natural diet. I avoid from supplements as much as possible if you are able to eat food. Okay, so if you are able to eat normal food, avoid supplements, take normal food, and normal food can give you all the ingredients that is needed for a healthy recovery.
Excellent. Okay, we have the question for Dr. Somnath Kundu over here. Yes, so the question for you is that can inhaled steroids be prescribed for persistent cough in post-COVID patients?
In fact, what I would like to say, inhaled steroids, along with systemic steroids, oral steroids, are concomitantly used during the active COVID infection. And if the respiratory, because lung is the primary basic organ which gets affected during a COVID year. So there is every possibility of the tiny alveoli getting damaged, which is irreparable, resulting to fibrosis of the lung. And there is also reactive bronchoconstriction also. So inhalation of steroids like budesonide to the tune of 800 micrograms twice daily per day is advisable.
Sorry, with someone who's having persistent cough post-COVID-19.
Yes. That's what I'm telling.
Right, okay.
Along with it, we can press an antitussive, a cough syrup, and Montelukast can be prescribed in combination with cetirizine.
Right. There's another question for Dr. Somnath Kundu and both for Dr. Gaurav Bahadur is, have you witnessed any, or have you encountered any patient who are having issues with their eyesight post-COVID-19 infection?
For me, any of my patients have not complained, but I am not the one who will get this complaint. It's usually the patient knows that a diabetologist won't be able to treat eyesight problem. So the patient will directly go to an ophthalmologist for this particular issue. But I have not encountered any of my patients. But yes, because the issue of mucormycosis is happening, it can affect the eyes. So this is something which our ophthalmologist friend might be able to tell us more in detail. And
right.
Conjunctivitis is also one of the symptoms of COVID-19. I have encountered one patient who was tested from outside as positive, and he was my diabetic patient for long. So he said, when I asked him about the history, so he was elaborating, then he said the first symptom he got was that, which got initially diagnosed as conjunctivitis by the ophthalmologist, and later on he started developing other symptoms, which finally led to the diagnosis of COVID-19.
Okay, and Dr. Kundu, what, in your opinion, have you come across patients, who are complaining of vision disturbances post-COVID-19?
Not yet. I have seen almost 20 plus patients, COVID patients till now. And till date, I have not come across anybody who has complained of neither eye problems nor hearing problem. Hearing impairment is also a new problem. It's a new symptom during the second wave of COVID. But fortunately or unfortunately, I have not encountered any such patient. Well, this blurring of eye may be attributed to long-standing who are already long-standing diabetics and with much increased blood sugar level due to the concomitant use of steroids. So diabetic retinopathy might set in, although it's a long-term sequela, but the blurring of vision may be attributed to that as well. But fortunately or unfortunately, I repeat, for my personal, I have not encountered any such patient.
Okay. Okay. So, Dr. Kundu, what are
there is one question from the.
Yep. Yes, please.
One question from the audience, that is there any role for gonadal hormone effect or any documented studies? So this is for Dr. Gautam Bahaduri. So any changes in the gonadal hormone effect or not?
Yes, actually, there has been a study, but the studies are usually small. So it would need a more detailed study to understand what's happening at that level. So what has been seen is a low testosterone level and increased LH level, hormone level. So there is a decrease in the testosterone is to LH hormone ratio. So this has been noticed, but till date, the clinical implication of this, this is more of a research-oriented thing. Orchitis, we have seen rare cases of orchitis happening in patients with COVID-19, but there was a very small study of around 80 patients. So they did this study where compared the testosterone level and the LH hormone, luteinizing hormone levels, and they saw there is a decrease in the testosterone and an increase in the LH in this patient when they were followed up at around 2 weeks of infection. So whether this is permanent and whether this is or is temporary is something that needs to be seen in the long-term course. But long-term data is not there with us. Large sample size data is not there with us.
Okay. Right. Okay, that's good.
Dr. Shomnath, there is a question for you, I believe. So this is an individual, who's just recovering from COVID-19 and says that, he has this particular symptoms like eye pain, pain in the face, and nose block and nose pain and headache. And this individual seems to be getting this once every week. So what precautions or what sort of treatment should this individual get into, or, what would you recommend for him?
He is complaining of post-COVID, aching of face and headache. Well,
yes,
this is one aspect which is being discussed very frequently now, a term called long COVID or post-COVID syndrome. So these symptoms, whenever they continue to linger beyond 4 weeks of recovery, and there are frequent patients returning to the hospitals with similar complaints. So for them, our advice would be, or taking paracetamol on SOS basis, they can use nasal decongestants like xylomethylazoline or oxymetazoline, and they have to go for to the registered treating doctor for further checkup.
Right. Okay. So as we are talking about, we've got it made expressly clear between the difference between type 1 and sort of type 2 diabetes, and what triggers and what we've discussed and touched upon briefly, was the potential hypothesis due to which this surge in hyperglycemia is being seen in patients these days. Any other anomalies, Dr. Bahaduri, which you have observed, and which interests you and for which, you yourself are struggling to find an answer?
The COVID has actually has not yet answered any of our questions. So we are always struggling for answers regarding COVID till now. So everything still remains at a very hypothesis stage, and we don't know the exact mechanism of action. So, and where it has potential, actions, we don't even know that. So most of the things that we discussed today are probable hypotheses that might be working at place to give this kind of results that we are seeing. But it will take more time to understand, because it's a relatively new disease. Everybody thinks that 1 year has passed, why we don't know. But in medical history, we take years and years to understand the disease. It takes maybe 2 decades, 3 decades, even to understand the basic pathology of a disease, and even that keeps evolving. So actually what I believe is that the general population has never been ever this interested in medical science and how it works. So this is for the first time, this is their first exposure to how the modern medicine works. It works on the basis of, they try to think about some pathophysiology, some hypothesis, and they try to test it out. They do a randomized controlled trials. If the drug is working, give a green signal. If it is not working, just throw them out. And this way they keeps on selecting. So Once a drug has clearly established, like we have understood that the steroids, they have a direct benefit in some of the patients where it is required, it will directly have a mortality benefit. So we have also understood that low molecular weight heparin will have a direct benefit to these patients who are suffering from COVID and whenever they need it. Not in all patients, but yes, definitely a subset of patients will be benefiting from it. We understood that oxygen therapy, yes, it has been also been saving lives. So from a big list of other medications, we are narrowing down, and this takes time. This takes a lot of effort. It takes years usually. We have actually been able to do it very, very fast. I would say the first time in the entire history of medical science that we are able to come up with a vaccine and at least 2 or 3 treatment options for something which is completely unknown. And because people are following it, because it is affecting everyone's life. So everyone is following the news, the updates. They are trying to gather more information about it. So they are understanding how evidence-based science works. It is nothing like a miracle out of the box thing. It works very systematically. It will take in those inputs which will stay, and then it has to go through the test of time as well as test of research. And if it is there, then we'll move the next step forward. So a lot of the questions regarding the kind of things we are seeing are still at a hypothesis stage, and we don't know for sure.
Of course, yeah, because if we take the case of cancer drug discovery or oncology, like it's been since like 100 years, we are still looking for answers.
Right.
But at least we moved on with this. You picked up a very important point of vaccination. Now, there are a lot of rumors going around that who should be vaccinated, who shouldn't be vaccinated, and there's a lot of vaccine skepticism in people, regarding. So a point which you mentioned that, people are gathering a lot of information, but too much information is a bad thing again. So
yeah, too much analysis. Yes, that is why I say too much analysis is paralysis. So it makes you uncomfortable, because we as scientists and researchers, what we do with information is a little bit different. We don't get puzzled by a lot of information. We try to deduce them and arrive at a reasonably logical conclusion. But that is not possible for everyone around us, because who are not into this. So a lot of information might sometime lead to, as I told you, a lot of analysis might lead to paralysis. So that is sometime might happen, and you won't be able to decide which vaccine to take, whether to take it, and then which vaccine to take, and at what duration of gap you need to take. So all these things will actually make you, a little bit uncomfortable in actually dealing with the problem.
Right. I mean, there's been some sort of, thing floating around that, people who are type 1 diabetic, I mean, should they get vaccinated or not? Or whether there's going to be any adverse effect if someone who has type 1 diabetes, should they take the vaccine?
Yeah, if they are eligible, because till now 18 plus is the category of age where we have allowed vaccines to run in India. So if somebody is 18 plus and having a type 1 diabetes, that is absolutely no barrier to taking a shot of vaccine. But the problem is that a lot of our type 1 diabetic patients falls under the age of 18, okay? Because it is usually picked up at very, very young age, okay? So maybe 5 years, 6 years, 10 years, in some majority of the patients in the teens. So though for those patients, the trial is still going on. So Covaxin, as I heard, has got that approval for trial in between 2 to 18 years of age. So they will be starting their trial on June, and they have told that probably, I heard in a newspaper that probably they are saying that they will complete it in the next 3 months if everything goes on smoothly, because there are some hiccups due to the second wave in actually performing the trial. So if that gets approved, then obviously we will be in a position where we can even give it to those patients who are below 18 years of age.
Right. Thank you. Dr. Kundu, I think, this may be a question for you, which asks, what are the initial symptoms of mucormycosis infection?
Mucormycosis is commonly, I would tell, the mucormycosis is basically a fungal infection. So many are calling it as black fungus, just because of the fact that there are black scars being developed. This is more prone to patients who are actually diabetics. And there are cases where mucormycosis have been superimposed on a COVID patient as well. So basically it is a a fungal infection, which we find in the roots of many plants and grasses. And mucormycosis is like mycelium. It comes from mucorales, but it's a network-like structure. Mycelium, what we call the fungus. So these are basically a fungal infection and might affect the skin, the eyes, the nose, the cerebrum, brain. These are the various, and also the GI. So what exactly is the question?
So what are the symptoms or signs which someone should look out for?
Mucormycosis. Okay, Gaurav, can you please elaborate on this?
Yes, so what happens is that mucorales group, this is what we call as mucormycosis. Exact terminology is not black fungus, but yes, it is being propagated because it is more catchy to, the common audience. So yes, you might refer to as any name as of now. It looks black because of the eschar formation. But the point of entry is because see, fungal infections are like somebody might have a bacterial infection, viral like COVID-19 viral infection, or you might have something called a fungal infection. Now, this is present in around us everywhere, but usually healthy immunocompetent patients do not get it. So healthy patients, they do not get it. What happens is that most of the patients who are getting it are usually uncontrolled diabetes. Okay, so unfortunately, a lot of patients in India, more than 80% of our patients in India are actually uncontrolled, even though they have diabetes. Okay, so researchers has been telling us this, and this is very unfortunate. So they have a HbA1c which is more than 7. So 80% of our population of diabetic patients are having a HbA1c of more than 7. But usually this uncontrolled V means a very high HbA1c level along with steroid use, and usually these patients are admitted in the hospital. So these are more being reported from patients inside the hospital because they are more serious and more critically ill patients. So they are developing it. So the symptoms is usually even as simple, because the root is usually the nasal root goes into the sinus. From here, they can go into the eyes and then into the brain. So it can be invasive. Okay. So, and it can be dangerous for the patient if it starts going in the root inside. So as simple as a nose block should not be taken, very casually in a patient, especially in a patient post-COVID or during COVID who is having uncontrolled sugars, along with use of steroids. And the patients, if the patient is in the hospital, then even the chance increases. But even if the patient is at home, then these things must be looked after. And usually the person to go to is usually an ENT. And if you have any inflammation or any pain around the cheeks or around the eyes, then again, it is something which has to be looked out. Even headache, sometimes sudden onset throbbing headache might start, but usually that is advanced stage. Usually you should have difficulty, from the nasal level itself. I am not the right person to say in details about this because I am directly not treating the mucormycosis patients. But yes, from few of my patients, I have sent them to ENT doctors, and they have been diagnosed with it. And though the numbers are very less for those patients who are not inside the hospital, but even post discharge, do not be very, if you have a history of uncontrolled diabetes and use of steroid inside the hospital, then even post discharge, look out for the symptoms and don't be casual if you develop any of these.
But in a nutshell, what we have discussed so far, that diabetes is one of the areas that we need to focus following or during COVID infection. And as an Indian subcontinent resident, we are in an endemic zone of diabetes, and we can have some unmasking of diabetes amongst our population, and we have to take things very seriously. Mucormycosis is coming a new thing, and this is the ENT specialist to look into in detail, and that has to be addressed appropriately.
So we'll move on to Dr. Somnath Kundu right now. So Dr. Kundu, what are the tests, your routine biochemical tests, would you advise, or you are advising your patients post COVID-19 infection, and for how long should they be monitoring themselves?
Well, the tests which are actually required for follow-up consultation, normally the first follow-up consultation should be within 7 days of the discharge. So when the patient comes back after 7 days of recovery or discharge, whatever, The primary blood investigations, which we advise normally, is a complete blood count. Then from there, we see the neutrophil lymphocyte ratio and the LFTs, the renal function tests. And along with it, there are 3 or 4 important markers, inflammatory markers, like in the likes of CRP, D-dimer, serum ferritin, and also serum electrolytes we also measure. And these are the blood investigations what we advise. And apart from them, an ECG and a chest X-ray is also advised to see the grade of recovery. And first follow-up, we usually don't advise HRCT, but we normally repeat HRCT after 3 months, HRCT thorax after 3 months, to look for the extent of lung recovery. Because as it is, we know lung is the primary organ to be affected. So these are the investigations we normally advise when the patient comes from follow-up post-COVID.
Thank you, Dr. Kundu. Dr. Baduri, another question is that, there's often, people rely a lot on glucometers, for their regular blood monitoring, measuring their glucose levels. I mean, I think a lot of the general public, they do not know the difference between, okay, what's the major, what's the difference, or what's the standard deviation one may expect between venous blood and capillary blood. So could you throw some light on that, please?
Yes, see, what happens is that when you are checking with a glucometer, you are actually checking the capillary blood glucose, okay? So capillaries are very thin vessels which form at the end of the fingertips, right? And venous blood is something from which the blood is taken when you are doing a laboratory testing. So obviously there will be some difference in between these two readings, okay? Sometimes some of my patients tell me, doctor, I have taken a sample exactly when they have taken sample from the venous blood, I've taken a sample from the capillary blood, and they are showing a little bit of difference. So is my machine error, showing error? No, not exactly. There's usually an accepted tolerance in between 10 to 11% in between the venous blood and the capillary blood. So capillary blood is not for accuracy; it is mostly for a general trend. So if your blood sugars are spiking very high, or whether your blood sugars is going down below 70, so it will help you in assessing the trends in the by measuring through a glucometer. So, and what it helps us in adjusting the dose of insulin also, because our general trend is sometimes more than enough to adjust the dose of the insulin. We might need a laboratory testing once in a while. And this difference will increase if the sugars are on the higher side. So suppose I'm telling you a 10% difference. So if your blood sugars is at 100, then the difference will be 100 versus maybe 110 or 90. But if your sugars are in 300, then this 10% would mean a 30 deviation up and down. So the higher the sugars are, even if the sugar machine is working perfectly, then also there will be a higher deviation. And actually what we have seen is the deviation is not constant across the sugar spectrum. So the deviation is more, it's less actually in the normal glycemic range. But the deviation is higher when the sugars either goes in the upper range or in the slightly lower range. So there is a higher chance of deviation in the extreme ends. But in the median range, in the normal glucose levels, this deviation is comparatively less.
Understood. So there is another question from Dr. Bagh is that, what are the more expected cases between hypo and hypothyroidism after COVID-19 infection?
Okay, so what we are seeing is a very interesting question. Thank you, Dr. Bagh, for this, because I was wanting to talk about thyroid because all the questions are mostly on sugar. I understand sugar is a bigger problem in the society right now rather than thyroid. But as endocrinologists, we want to talk about something else than sugar sometimes. And what happens is that with the thyroiditis is being seen. So let me tell you what thyroiditis is. It is the inflammation of the thyroid that leads to I would suggest kind of for easy language, a leakage of thyroid hormone from the thyroid reserves into the blood directly. So because of that, you might see increased thyroid hormone levels in the blood, resulting in thyrotoxicosis. And later on, this thyrotoxicosis stage might go to hypothyroidism later on. Okay, so all patients will not be there in the permanent hypothyroidism. Some patients might come back to the euthyroid or the normal thyroid levels later on, but some patients might be on a permanent hypothyroid state for a very long time. So thyroiditis initially, obviously, will get thyrotoxicosis. Okay, so I don't want to use the term hyperthyroidism because it usually means that the body, the thyroid gland is producing excess of thyroid hormone. But thyroiditis, that doesn't happen. It is leakage from the reserves, which is coming directly into the blood, not via the normal checkpoints. It is a backdoor entry of thyroid hormone into the blood because of thyroid inflammation. There is a leakage. So in this particular cases, the body heals the leakage usually by itself. If it is a subacute painful thyroiditis, there is a swelling in the neck over here, not here. This is a tonsil glands. Okay, so some patients come to me and say, I have pain over here. Is it thyroid issue? No, your thyroid gland is there in the midline over here. So if there is an inflammation swelling over here, then we suspect that there is some painful thyroiditis. Again, thyroiditis can be painless also. So you might not have pain, but you might still have thyroiditis. So usually painful thyroiditis, we can treat it with either anti-inflammatory and steroids. We can treat it, and this usually the steroid is tapered over a period of 4 to 6 weeks, and this way we can take it into control. But these patients can later on go on to develop hypothyroidism. So both the possibilities are there. In the acute phase, you will see more of thyrotoxic cases because of COVID-19. Later on, you will see these patients, a substantial part of them turning into hypothyroid also.
Right, doctor. So in these cases, patients who are asymptomatic, what sort of tests can they do, to actually figure out?
Usually in the sick patient, we do not recommend thyroid hormonal studies. Okay, so patient who is suffering from COVID-19, having fever, okay, taking medication, we usually don't suggest it until and unless the patient, there is some symptoms like I told you, the gland is swollen and there is pain. Okay, some symptom which is related to the thyroid, we would not suggest testing the thyroid because the thyroid levels might change because of the sickness. So it will give you a false impression. So once you are out of your acute illness, you are in the recovery phase, you can check for a TSH and a free T4 levels. I would suggest that it is better to get consulted with a doctor who is specialized in this domain. And if you see there is any abnormality, then we can go in for other antibody testing, as well as if there is to differentiate whether there is a thyroiditis, that is a leakage, versus excess production, that is hyperthyroidism. Then we might need to perform a technetium per technet thyroid uptake scan also. So that will actually help us in understanding it in even more detail. So receptor antibody testing like TPO and PSH receptor antibody along with technetium per technet thyroid uptake scan can help us delineate the exact cause of it. And if it is a thyroiditis, then we treat it separately. If it is a hyperthyroidism, then we treat it separately. But usually hyperthyroidism you will not see directly because of COVID. As of now, our understanding is it might change in the future. But right now, we are focused of COVID-related thyroiditis.
And final question for Dr. Somnath Kundu before we wrap up. How long is SpO2 monitoring required post-COVID-19 infection from someone who's recovering? How long would you recommend the person to check their SpO2 levels?
We have already seen and it's recorded that with 1 in 4 recovered patients turning up at hospitals with post-COVID-19 infections, we should not let our guard down. Just because of the fact that we were already COVID fatigued from the first wave, and we were getting more and more complacent, the second wave had struck. And that proved a lesson to us that we should never put our guards down. Even after recovery, we should be alert. So, as I was telling, that recurrence of fever, to cough, to breathlessness are all post-COVID complications due to fibrosis of the lung, which results from the scarring of the lung tissue due to damaged alveoli, which are irreparable. So there is every possibility that oxygen saturation might fall every now and then. So oxygen saturation must be monitored, and that too regularly. And as I had said earlier also, an HRCT scan should be repeated after 3 months and then after 6 months to see the progress of recovery. So these two things should be kept in mind.
It's good.
Right.
Nice presentation by Dr. Vaduri and Dr. Kundu. So it was very enlightening discussion.
I just want to interrupt for once. I can see one question
Yes,
in
Dr.
the. Yes, I can see one question which is I think is very important for me to answer. Sampika Chatterjee has posted this question. So, how do you advise patients to monitor blood sugar at home on steroids? So, this is again very important. Understand that steroid usually causes a postprandial surge in blood sugar levels. Okay, so it is mostly the PP which will rise. And if you are usually we ask the patient to take a single dose of steroid, entire dose of steroid on a single point of time. So usually it is the post breakfast. But if you are taking twice a day, at night also you are taking a dose of steroid, then that might have an adverse effect on the fasting because of the post sugar will increase, and that increase will keep on seeping throughout the night and will raise your fasting. But if you are taking a single dose of steroid, which is usually and the type of steroid is also very important. So if you are taking a methylprednisolone or a prednisolone, so these are usually intermediate acting steroids. So what classically you will see is if you give a steroid post breakfast, the blood sugar will start actually rising in the post lunch. It will take some time. Okay, so that is why the NPH and the regular insulin are of extreme use, whereas human insulin becomes so invaluable in the treatment of steroid induced hyperglycemia, whereas in all other cases we favor more of analog and designer and third generation insulin. But this insulin can also take very good care of those patients who are on steroids because of the timing. Okay, so and remember that usually there is a postprandial increase, and that increase also takes some time to do. So if you take post breakfast and you check up after breakfast, if you take a steroid and you check your blood sugars 2 hours after breakfast, you might see a very mild increase, but you might see a greater increase in the afternoon. But that is different if you are taking a longer acting steroid like a dexamethasone. Then your sugars might be higher on even the lunch as well as the dinner. So accordingly to the kind of steroids the patient is taking, and depending upon the dose kind of dosing, morning, evening, when the patient is being dosed, depending upon that you need to advise the SMBG or the self monitoring of blood sugar accordingly. So you have to consult with your doctor to ask him that when should I check my blood sugar levels. And another question is that do you do a baseline HbA1c at the initiation of treatment? Yes, this is very important. Most of our patients, we will do a baseline HbA1c if we don't know about their HbA1c status previously.
Right. Dr. Bhaduri, there's someone from the audience who actually wishes to talk to us. So his name is Mr. Gautam Saha. So yes.
Sir, I have got my answer regarding my low BP, but regarding my persistent cough, little bit cough I have. Today is my day 27, and I have a mucosal secretion also for my chest and larynx. So regarding this, please advise me, sir.
Actually, this post-COVID cough is a very common day. And the most important this thing cause might be due to secondary bacterial infection.
Okay.
This is because as it is viral infection suppresses the immunity of the concerned patient. So secondary bacterial infection is to be kept in mind. So an antibiotic may be prescribed in the form of theropenem, and for 5 days. Along with it, you can have this montelukast levocetirizine combination for a period of 20 days, and add to it any cough suppressant, antitussive like Brilintus. So you can try this, and you get a. Have you? The point is whether you have done a HRCT thorax during the course of your this thing.
No,
so
sir. I did only X-ray, sir.
You did X-ray. Then you need to get a HRCT thorax done, because X-rays might leave many things undiagnosed. Okay. In COVID infections, HRCT give you the minutest of the detail. So there might be some inflammatory changes and in the lung, which might go undiagnosed in X-ray. So what I would suggest is you get an HRCT done, and that might clinch the diagnosis.
Okay, thank you, sir.
Okay. Okay, so with this, we'll wrap up. And just to surmise and what we discussed today, that, we are observing this alarming trend of diabetes and hyperglycemia, which is emerging right now post COVID-19 infection. So I think the message taken from here is that, even after post-COVID, on the road to recovery, one should be constantly on the guard, should keep a lookout for anything which is unusual, symptoms like excessive sweating or dry mouth, which might suggest that, okay, there is some metabolic alterations going on, excessive, fearing of urination, etc. So, and it is essentially important, as Dr. Bhaduri mentioned, that, if someone is or was diabetic before the COVID-19 infection, so post-infection on the road to recovery, to keep a very stringent watch. Also, with people with family history of diabetes, I think Dr. Bhaduri, you would agree with me on saying that, they were probably not diabetics to start with, but post-COVID-19 infection, it would be wise enough for them to get a routine PP, fasting blood sugar and HbA1c done. So, so we have all agreed on this, and I think it was a wonderful session where we had Dr. Kundu and Dr. Bhaduri, especially Dr. Bhaduri speaking from his point of view as an endocrinologist, and Dr. Kundu speaking from his experience of treating COVID-19 patients and what has generally been observed. So, thank you very much, all of you. Thank you, Dr. Shumanta Datto, for helping me co-chair this session, and we wish everyone all the best, especially in West Bengal, where we are going to be hit by a cyclonic weather now. So it's one thing after another. So everyone stay safe and look after yourselves. Okay, goodbye, and a very good evening.
Thank you very much. Thank you.
Thank you. Thank you. Thank you.
Bye-bye.
Bye.
Bye-bye.